Hello and welcome. Today I am joined by Andy Franklyn-Miller. So Andy's a doctor, but he is currently Chief Medical and Innovation Officer at Nuritas. So I'm very much looking forward to hearing about his journey and what he's moved into now. So Andy, thank you for joining.
Absolute pleasure. I'm looking forward to it.
So whereabouts are you? I know you've been traveling around a fair bit recently. So where are you speaking from?
I'm speaking from London, and my role currently is split between Dublin, London, and it's fair to say the rest of the world, which is really exciting. But it's a work from home day, and it's a pleasure to be talking to you.
Great. So so talk to me about your current role. I know it's a really recent thing that you've done, and I've known you from your work in Santry, but just talk to me about what you're doing now.
Sure. I broadly left medicine. We'll talk a bit maybe about my career in general, but currently I'm Chief Medical and Innovation Officer at Nuritas. It's a biotech company. In essence, what we do is combine artificial intelligence and machine learning platforms to identify peptides from a natural source, so not synthetic peptides, but a natural source, and look to find a human application as a supplement or as a food source. And one of our current products is Strong, and it's peptides that work on muscle production and increased rate of muscle, both force amplification and muscle turnover and muscle growth, but also anti-inflammatory effects. And we've taken that through clinical trials into commercial sales, and we've Strong within GNC products and about to launch in Europe with a range of products. So we're B2B rather than B2C, and I have my role covers everything from the proteomics mass spectroscopy laboratory through biology, through data science, machine learning, through the regulatory minefield that's introducing products into the food chain, along with legal, but also a lot of work with venture capital and the company direction over our next Series C funding and the like.
Yeah, that sounds like quite an in-depth but exciting challenge. So what made you want to move into sort of that type of role?
Do you know what? I think as a physician, you are limited in your ability to create impact. I've spent the last 10 years prior to this building sports medicine for the Sports Surgery Clinic in Dublin. And we've taken that from 500 patients a year to close on 50,000 patients a year. And we were successful, both as a business, but also from a research perspective. And we published 40 papers or so, particularly on biomechanics of rehabilitation, and trying to take big data and engineer a solution whereby there was less variation. So I'd always thought that rehab was a very subjective tool, unlike maybe oncology or cardiology even, where you had some hard, fast data that you could use to guide your treatment. We don't have a blood test. We don't have a screen in hematology for rehabilitation. We don't have objective data. We wiggle the leg or we look at someone and say, hey, that's how it works. So biomechanics was the ability to get 250,000 data points per second of movement and see if we could take some artificial intelligence, some neural network and mind mapping to see if we could identify features that could affect rehabilitation. And that journey was taking us a long way. And I began to understand how we could use data to give better clarity and objectivity. But when it came down to it, yes, we could scale the business, we could open another clinic, we could see more patients. But through COVID, we looked at the huge impact metabolic, cardiovascular, longevity has on the population as a whole. And so I ran a clinical trial for Nuritas, saw the potential benefits, and really it's the opportunity to help millions, potentially billions of people is irresistible. It takes away that limitation of face-to-face contact and needing to be able to see someone in order to diagnose and prescribe that medicine will never give on its own.
Yeah, no, absolutely. And was that you mentioned about the business elements and Santry, an amazing success. Everyone really speaks very highly of it. So was that something that had you always been interested in, the business aspect of things and that side of it alongside the clinical?
I think my journey is interesting. I started as a rowing coach, and so when I left school, I was very fortunate to be coaching two guys who were very talented. And I took 2 years out between school and university, and I coached those guys, and they rowed for the Great Britain junior men's team. Um, that got me an opening, and I was a young 19-year-old coach coaching ultimately senior athletes within the Great Britain program, and went on to coach at the Junior World Championships, and then under 23s, and then carried that on through medicine. And my interest in science was stimulated by my want for crews to go faster. So I started a degree at Newcastle University in physiology and microbiology. After a year, transferred to what was then Charing Cross and Westminster Hospital Medical School, that became Imperial, um, and coached through that. And so I was lucky enough to coach St Paul's School in Barnes in London to win the Princess Elizabeth at Henley. And at the same time, I was coaching Imperial College, and half of that squad went on to win gold in the men's eight in the Sydney Olympics. So I'd been around rowing and performance, and so sports medicine would have been a natural fit. But yet I joined the Royal Navy in the middle of medical school. And someone asked me actually last week why, and I think it was the challenge. It was the opportunity to do something a different way to everybody else, and the rush to get fellowship in exams and medicine is an ongoing learning process. And I think the rush for exams didn't appeal. I have to say that actually, after my first house job, I changed my mind, and I was desperate to get on with those exams, and the military stopped me from doing it. But when I look back now, it was a good thing. But I did 16 years in the Navy, and 3 years with the Royal Marines, deploying and learning, where really you're thrown at the deep end. You're a GP who's got no training, you've just done your medical training, and then you're responsible for a medical centre, 1,000 or 2,000 men at the time, now men and women, and you've got to provide a solution. And I loved that. It was one of the most exciting parts of my early career. Was it was you and the resources you had, and you had to provide a solution. And I learned a lot from that. And I went back into hospital training after that 3 years. Started as a thoracic surgeon, but then was very fortunate to be offered the men's team doctor role for British rowing, and the Navy thought that was a great idea, but that didn't really fit with thoracic surgery, who wanted 22 hours a day of your life. And so I changed tack to general practice, so I could work around the rowing and combine both for a while before starting the range of military jobs that it offers you outside of medicine. So I've done everything from look at infection rates in Royal Marines from a microbiology perspective, to look at smoking rates within the Navy, to be an advisor on swine flu and the management within the Southwest, through to being a ball officer, to looking after beagles, to being the principal medical officer at Britannia Royal Naval College. So the diversity of my job, I think, set me well, and it's always been interesting. Where does business come in? I think business comes in eventually for want of a change. I'm a natural problem solver, and I want to provide solutions. And one of my biggest frustrations is seeing either wastage of manpower, in the sense that people are not given the tools to do their job, or that I think there's a better way to do something. And so after a brief spell in Aspetar, I was recruited to the sports surgery clinic, to build a practice within an orthopedic hospital. And on face value, that sounds pretty easy. You kind of think, listen, we've got 40 orthopedic surgeons. Surely there's a lot of sports medicine available. But it was actually a pretty big challenge, because orthopedic surgeons are proprietary in many respects. That everyone's an independent practitioner. It's not like a big practice. So patients are your revenue stream, and sports medicine, it's a new specialty. Its raison d'etre is to avoid operations, to create activity and provide an exercise-based solution. And I thought there was a better way. And so the Navy gave me the skills, undoubtedly, in terms of leadership and management training. And I've been very fortunate to find mentors along the way to enhance that from a business and commercial aspect. And working with the likes of PwC and McKinsey to gain insight that I wouldn't otherwise have gained. But I think it's always been there. Like it's a quest to do things better, rather than continue in someone else's role.
Yeah, I mean, there's a lot to unpick there, and it's just to going back to just how you started out. So, are you from London originally?
No, I'm actually from Newcastle. Not that
Right.
you'd guess. It's not that you'd guess. But yeah, so I went to school in Newcastle, and my mother's Norwegian. The school was very formative in many respects. I think I learned a lot at school. I wasn't by any way the most academic. I wouldn't have got into medical school without coaching, and and I think when I look back, I think medical school suffers a lot by its admission criteria, and I think it's got worse. I'm very fortunate to sit on a number of panels for interviewing for medical students, for acceptance, and the way medicine's gone is unbelievably competitive and therefore incredibly academic, and I wasn't that academic. Um, I struggled, if I'm honest, at school in terms of maths and physics, which is somewhat ironic now that I work within a very mathematics field, and have a PhD in biomechanics. But it it people develop at different rates, and I think the acceptance of education is interesting. We expect people to be a jack of all trades, which we learn later on in life is unrealistic. If someone shows a natural aptitude in art or a natural aptitude in computer science, why do we force them to do other stuff? Why do language learning, or why does physics become vital for the artist or the musician, or the actor? It makes no sense to me. And so I I value education a lot, but I think the mode of education needs to change significantly.
So then, for when you're in Newcastle, and then how did you become a rowing coach then?
So great story. There was a physics teacher at the school, a guy called Roger Tarry, who had introduced rowing to a school which wasn't a natural rowing school; it was a rugby school. And he had a very good program. He'd taken people to Great Britain rowing before, and you could start rowing in what was then fourth form. So GCSEs was when you could start rowing. I started rowing because friends of mine at the time said it was a great ticking the box to get into university, and took to it, loved it, absolutely loved it. I loved the fatiguing elements of it, the complexity, and actually now the physics of it. But at the time, it was just hard. Roger left after I finished my GCSEs, and they couldn't find anybody else to take over, and so rightly or wrongly, I took over coaching, and so did it very ad hoc through my upper and lower sixth. They had a couple of masters in charge of rowing who weren't coaches, but I went through a whole set of formal coaching qualifications with the Amateur Rowing Association, and was clearly a novelty because I was learning to coach among teachers primarily, but people who were 10, 15, 20 years older than me. And so this novelty was really useful, and I therefore broadened my knowledge and started to coach at the school and outside of the school. And then when I was due to leave post A levels, the school said, "Well, hang on, we've got some pretty good rowers. What are we going to do?" And I was offered a job, so I went back as a member of staff to the school, the Royal Grammar School, Newcastle, straight away, which was bizarre in a way. My parents had struggled to pay the fees. I was going back as a teacher. It was a great opportunity to learn how things worked, and I think that's very formative. To see the school structure from one side, and the next day to be in the master's common room, seeing it from the other side, and have those relationships change instantaneously was fantastic. And look, at many schools, you know, do that very well. My kids go to Millfield in Somerset, and Scott Draw is down there as head of sport or head of performance, and they've got some great new grad or post school leaver programs that really embed young coaches within the environment, and I think everyone benefits from it. I think it's a really positive thing.
Yeah, no, absolutely. And yeah, I know Millfield, I know one of the tennis coaches that was there, and incredible facilities as quite a few of these setups do. So for you then, so if you hadn't have taken that job, what were you going to do?
It's a good question. I didn't have the grades to get into medical school, and so my logic was do a basic science degree in physiology. In my head was make my crews go faster, but rowing coaching was it. I wanted to be a rowing coach. It was my, and still is in many respects, my passion. Um, at the time, careers in it were pretty few and far between, and so it would have been a very piecemeal existence. The Amateur Rowing Association at the time had a national structure of regional coaches in terms of development, but I was about winning. I wasn't about teaching people to row necessarily, and and so I guess the path would have been into schoolboy rowing or schoolgirl rowing, and I would have ended up as a teacher of rowing. I think is probably what would have happened. The 2 years out allowed me into a national team structure. I gave me insight into where I was going, and that drove me through that coaching path. I applied to Charing Cross, who had a dean who was a big rower, Roger Greenhalgh, who said, "Yeah, there's a place here, an unconditional place if you coach rowing." And I coached the women's part of the club for a year. And I'm very grateful to him for that opportunity because I wouldn't have got it without it. And I lament the lack of that opportunity now.
Isn't it interesting though that so many people I've had this chat with, even I was chatting with Pippa Bennett yesterday, and she was saying, well, I'm not the most academic, but you kind of, your network or you speak to someone, you're given an opportunity, and then so many of the people I chat to that really impressive roles, done amazing things, but all of them are saying a lot of the same things, which does go back to your point about, I suppose maybe people do find a way through, but how many people are being lost from the purely looking at the academics?
Yeah, I think you learn from failure. We touched on that, pre-call. I think you need to fail in life, and I think people are very frightened to fail, and I've failed repeatedly. I've made bad decisions. I've given time whereby there's very little return, or I've exposed myself to risk that I really shouldn't have. But every step along the way, you learn, and and I guess was I setting myself up for a medical career now, you'd approach things very differently, and if you want to make an impact in people's lives, certain specialties are very hard to do that from. And no one teaches you that. There's no go-to medicine, and I think it's very similar in virtually every industry. Unless you've got contacts within that industry, it's very difficult to actually understand how to succeed in it or how to set yourself up. You don't need to look at Google's hiring structure to understand that for the vast proportion of people, you need four languages for most of their roles that are high earning. How do you know that? You don't know that. And so, how many people at school identify that actually they want a successful career within tech that works across Europe, that multiple languages are a significant advantage? We look down on people who struggle with languages, and we don't have the capability to switch. My kids have been in school in England, in Australia, in Ireland, and now back in the UK, and being able to the continual language from one curriculum to another was impossible. They were learning German and Japanese in Australia, went to Ireland, had to learn Irish, came back to the UK, and Latin and French. The continuity of education in terms of what ultimately happens is not there. And I think the ability to understand what a job needs is the bit that's missing, and it's left to the individual. And I think if you're not willing to fail, then you get stuck within a stream that's actually pretty difficult sometimes to get out of.
Yeah, I definitely agree. And like even just with the conveyor belt that you're on in school of, you go through GCSEs, A levels, that's like if you've not done that, you're almost all right there. Then they're not, we used to recruit purely if someone had a degree, and now I'm completely the other way. It's like, well, it's based on the personality and what they can bring, and it's more about the energy, I guess, that we look at really, or the attitude. So yeah.
And I share that. And I think one of the best performing teams I've worked with was under John Fletcher in England Rugby in the under 18 setup. And Fletch had he's a natural type A, yellow personality. He makes you smile and he makes you engaged no matter what he's doing. And he built a team around age group rugby, which was really the Stuart Lancaster pathway, and built a phenomenal hierarchy of success through under 18s and under 20s that vanished as the hierarchy was changed. But he built a team that evolved around, to some extent, insights profiling. So he had his reds, his yellows, his greens, and his blues, and he built a team around it. And it was the first time at interview that I've been asked about emotional intelligence. And I think our underselling of emotional intelligence is incredibly remiss. I think people's skill sets to do a certain job, it's around what they've learned in their life. And some people are brilliant at being able to engage with people of all sorts of walks of life, all sorts of levels of intelligence, and others can't. And if you put someone who can't in a front-facing role, you're setting them up to fail. And I think it's really difficult. And I try to bring that element of recruitment through to SSC there, but it's an ongoing challenge, because when you're in a medical model, there are certain benchmark skills you need to have in order to build that team, and there's no shortage in sport, particularly in S&C, of red personalities. You know, there's plenty of them. In terms of the yellow, the green, and the blue, how do they fit into a commercial environment, which is not sport? It's a challenge, and it's difficult to find people to fit. Physiotherapy is the same. Medicine's a strange fit, because what will make a good research doctor doesn't necessarily make a good commercial private doctor. And for 10 years I spent totally in the private space, and it's a different requirement. It's a service industry, and that ultimately comes down to it. You have to be able to serve your ultimate clients, and I think it's a challenge. But I learned a lot from Fletch. His approach to building that team and taking something outside of the base tenets of what you needed was remarkable. And he had a phenomenal relationship with many of the current senior team who progressed through that pathway, based on it, in terms of empowering the individual to understand their strengths and weaknesses from an EI point of view, as well as from a rugby point of view.
Yeah, no, I think that's really interesting. And someone else was talking about that regime as well, and saying there was like some really, really good things that went on. Yeah. And just to reflect on that, we recruit. We've had a lot of graduate sports therapists that work for us, and we recruit, whether it's a rehab, physio, and we've just found that, like, physios, again, just from our experience, it comes in with a very different personality type to sports therapists and rehabbers, which maybe they're not able to go down the conventional route, and they've got to adapt, and they've got to add those extra skill sets on, because they're not HCPC, and they've worked really, really well for us. We've employed them as contractors physios, but they've never been part of the organisation, because the personality fit was just better in my view, in the rest of the team's view, to fit in with what we wanted in terms of versatility and what is just in the way that we work.
And I think it goes back to that competitive landscape. For whatever reason, physio is incredibly competitive to get into, and so then if the benchmark is academics, you start to lose the reds and the yellows, and you go towards the blues and the greens, who are driven by success within that academic field, because that's where their success has come from. And I think it's difficult to deviate from the norm. Clearly, people do. There's no, it's not an identikit structure, but it's an interesting challenge to cross, and it comes back to education, which is where we're starting. We expect people to be excellent across the breadth. We don't allow deviation from the norm, and people follow the same model. And I guess that's why the apprenticeship model in some countries works so well, because you can take someone who's very driven, and vocation, I think, is the wrong word, because actually vocation doesn't necessarily mean a trade. It doesn't necessarily mean a direction, but I often think, for many of the guys that end up in let's say general practice, that general practice journey could start very early on through medical school. If you wanted to be a cardiothoracic surgeon, there's an awful lot of stuff that's not necessarily needed through medical school, because the end result doesn't require the various component parts. And so the question is, what do we train? And I think it goes back through to secondary education. What are we training for? Is it just a set of hurdles to occupy time? And are we artificially therefore ranking people? And you only need to see the trouble with Ofsted at the moment in terms of how schools themselves are ranked, to know that the grading systems don't necessarily make any real sense. And it's a challenge. I don't know how to solve it. But I think, for the end user, when we're recruiting, we need to be aware that actually there's real talent lies deep in the CV rather than necessarily on the component parts.
Yeah, no, it is like we've put adverts out and you get 100 CVs, and it's like, then I remember we had one. So we did it. This is through Indeed that we did it. We had 100 people came through, and then we put this. There was this layer that you could put in there where you had to answer questions, but on audio. So we thought, that's quite interesting. We'll put it in. And I remember one particular guy, like he messaged me directly and said, "You're completely out of order doing this. You're going to lose so many people by asking these sort of questions. You're going to get the wrong person because you have to go through these hurdles, and it's just not going to work for you." And I was just like, it's correct. This is well worth doing purely because you've just ruled yourself out purely by your response to a pretty innocuous thing to put in, really.
Yeah, and I think we have to be open to how we to improve. One of the things that I was always adamant about was actually we read every CV, because you're right. You can open an advert, particularly for strength and conditioning coaches, where you might get 160 applicants, and broadly speaking, I would say everyone has done everything by the book. They've interned, they've got an Exos qualification, they've been over to the States now. They've probably worked with Jonas and done some sprint analysis. They've ticked every box going, all at their own cost. They've got an MSc, they've self-funded, they're working in 3 different jobs. And you owe it to everyone to read those CVs, but it's a nightmare to try and stand out. It's lots of that work. You read the discussions on how much is an inside job versus an outside job, and how people can break into various fields. And I think one of my big successes has been to try to make S&C mainstream within medical practice. And I think Neil Welsh, who got his PhD with me at Dublin, has done an amazing job of defining S&C's role within rehabilitation, and showing really how it can be an incredibly cost-effective solution, because coaching is missing in both, I think, many of the physiotherapy roles, but also medicine. And one of my advice to all of my registrars over the last number of years is that we need to develop an ability to impart information, and that's where coaching comes in. I think it's why S&C does so well in rehab. Rehabbing injured patients is no different from rehabbing or training uninjured individuals. I did 6 months with Great Britain Hockey over the last 6-8 months, and the integration of strength and conditioning within GB Hockey was a fantastic thing to see. In many respects, S&C were taking on a very early lead in rehabilitation of athletes through pretty innovative matrices of return to running and return to hockey. But those S&C guys had some hockey coaching experience, and I think it shows very, very clearly how they can talk 1 minute to a coach, talk one to an athlete, and then talk to the medical team. And I think it was a very nice blend. Emma Batchelor, as head of medical services there, has done a very good job of smoothing that transition. But the utilization of support staff is very important, I think, and you coaching and the ability to get information across to people is always a challenge, and something that across the doctors that worked for me in Dublin, we were very keen to try and do in terms of a common language, how we explain things, a tendon pack of dry spaghetti, tendinopathy, wet spaghetti within dry spaghetti, what we were trying to do at a cellular level, but in terms that people would understand, and use that analogy as we describe the MRI images rather than relying on reports. And I think that makes a big difference, using those analogies to patients that you would use when you're coaching, as well as visual cues. And I think a lot of that translates, and it's missing from medicine. You only need to hear about a bad consultation where it's been in, out, he didn't touch me, he told me what was wrong and I needed X. That's awful. We don't serve a patient's needs in that.
Yeah, no, definitely. Like S&C is that was a big. We were at Therapy Expo last year and met up with Andrew McCauley, who's he's done really well with his S&C course for physios, and I think there's a massive, does seem to be a massive gap for that, and there's the demand for that sort of education is really growing, which is good, isn't it? And even from like the biomechanical standpoint, chatting with Phil Graham Smith, who you may know as well, and he's saying that a lot of that biomechanical thing is being adopted now in whether it's VALD or all of these different things that are coming in from the higher end motion analysis things. What's your thoughts on that for me? Because you've biomechanics as your side.
Yeah, it's a really good question. So my thoughts, my background in biomechanics came from the military in the sense that we very regrettably had a large number of servicemen and women who'd lost limbs in conflict, and the available understanding and management of that fortunately hadn't really been seen since the Second World War. And so there was a dearth of data in terms of the mechanics of and the metabolic physiology of learning to walk on prosthetics. And so we were building biomechanics around trying to understand the metabolic demands, the changes in prosthetics, the changes in stump quality, to try to make life better for a large number of people. Biomechanics is a phenomenal tool. And I started to translate it across to sport on the basis that if you have a high value athlete, is it good enough that we use video or manual palpation to make an assessment when we have that available technology? But it has an error rate. And a lot of work we've done over the last 2 or 3 years in Dublin was very much around trying to quantify that error of the gold standard. And motion capture using infrared cameras and reflective markers is the gold standard, and there's a significant error rate. So every step you move away from that, so you go to a markerless system or inertial sensors, or force plates alone, you take them out and start to try new algorithms, and then you go back to video, enhances that error rate. So for example, you might have a 30% error on hip internal rotation using a full motion capture system in the laboratory. It's impossible to quantify that error the further you go on. So I think the analysis and the interpretation of data is poorer the further you go away from gold standard, and that will always be my impression. Of course, the manufacturers and the sales of all of these systems will argue in a very cherry-picked solution they're accurate, and certainly they are. You know, the VAL data for knee flexion and ankle flexion angles are great, and you look at Kitman Labs, who were using Xbox cameras initially to do shoulder range of motion and ankle shoulder range of motion with an Xbox camera. The error rate must be enormous, and I know from our work with Del Fanning, who's in a final year of her Ph.D. in Dublin, looking at return post reconstruction shoulder. We've got a test battery of 10 or 12 tests looking at shoulder movement in a motion capture lab, incorporating force plates and dynamic movement. And yes, you can pull features which are most relevant. And it may be that elbow flexion angle or the rate of elbow flexion is very important, and that can be extrapolated down, but you don't get the full picture. So I think at best you can extract single features from data sets that are much larger at gold standard and rely on those features. And I'm fine with that. Kitman used to use ankle dorsiflexion range as a predictor for injury. I don't know whether they still do. To me, that's cherry picking data for certain conditions. And we published work in ACL rehabilitation using features that were able to discriminate against the risk of re-injury and injury. And ankle dorsiflexion is important, but it's the rate at which that changes. So it's your ability to produce force across the ankle that you can't detect from a range of motion. So that's not range, it's the rate of application of force. And I think our ability to change that is clearly through training. One of the interesting things about when I joined Nuritas in terms of is there nutritional elements that can make that effect? Peptistrong in the trial that we ran at Sanctuary had a force amplification effect. So you can take an extract of fava beans and give that in a very small cell signaling dose, which can cause an increase in muscle force amplification, either through ATPase production or calcium metabolism at the cell. So it's not necessarily just about training, but the measure that we look at is really important. And that needs to come from large data sets. It can't come from small data sets. And we have to be cognizant of the error that every subsequent dilution of the data gives us.
So what is your thoughts then on like the kind of the more mainstream adoption of this sort of tech that people want a number? I mean, it's saying that it's been used for a long time, like with bioimpedance analysis systems, which you could really question a lot of the accuracy of those things and when they're done and so on. So what is your thoughts on like the new tech that's coming out there for any of these assessments, which has got very questionable accuracy?
Yeah, sure. And I think, look, there's always a quest to chase objective data, and I think makes life easy because it becomes binary. And I spend my time now working with machine learning, where we really need code in order to allow us to interpret an outcome, because obviously all machine learning is math, and so you need a binary element in terms of yes, no, in order to proceed. So there's an attraction. The reality is, does it affect patient outcome? And I think one of our biggest efforts in terms of the work we published over the last 10 years from the Sports Surgery Clinic was we tried to produce clinically transferable measures, so that you didn't need a laboratory, that you could take work on measures as prescriptive tools in certain scenarios. But that took 700 patients, it took a team of 12 people, and it took 15 publications to provide those variables. So the chances, if you're a club, of taking a data stream from within the club, which usually you're sharing in a de-identified way from the people behind that system, so they're learning from your data, is pretty slight. You can use it to reinforce your own ability, and that's fine, but you're not going to gain necessarily any enormous insight out with a large data set that someone else is going to own. And data sets naturally should be proprietary because there's great value in them. And so if you're a football club, you might learn something significant looking at your academy players over 5 years. But are you going to learn something by introducing force velocity analysis in year one without having complete control over the training program? No. And I think it's almost applied at the wrong point. So who designs the training program for the club, the competition schedule? Who designs when a session's hard and when not a session's hard? Everyone's an influence aside from the coach. So ultimately, if you can't change something, why measure it? You're just adding noise to the data set. And I think the danger at the moment is we're adding noise without a clear indication of what we're trying to do. And that's what I was very cautious of. I didn't want to. Clearly, not everyone can have a 3D lab in their practice. It's expensive, and it doesn't allow widespread adoption. But labs with a decent enough source of patients, and one of the benefits of Dublin was we had an enormous number of patients. So we were doing 1,000 ACL repairs or reconstructions a year, and that was a steady stream. If you're a university, you might get 20 of those, and 10 universities are unlikely to collaborate together. So there's a problem with data sourcing. And I know ISEH with Faris Dowd have just started to recruit to try an NHS trial in taking some of the data that we were using in post-ACL, see if you can bring it into the NHS. And I think that makes sense. But ultimately, those large data sets and that lab need to extract features which can be interpreted by the lower down systems. And I think the danger is they're sold on giving you the same data set that the gold standard will give you, which they never will. Yes, they'll be advanced in technology, they'll become more accurate, but ultimately there's an error rate that's not worked on. And I think Kieran McFadden, who left Dublin recently, is part of his Ph.D. at University of Roehampton, looked at those error rates, and in time they're quite substantial. And it's down to the quality of training of the staff who are putting on the markers and the measurements of markers. And that obviously has an element of human error. But also, if you kind of imagine skin, fat, muscle all move. And so even though you're putting a marker on a bony landmark, you don't know for sure it's there, but you've got a marker. As soon as you take markers out of the equation, you don't know what's moving. And as soon as you take those 3 or 4 cameras out of the system and go through a single iPhone, you're using algorithmic extrapolation of data, which is of poorer quality. So it's a challenge. And I can see the attraction. And who's an S&C coach who hasn't got force plate data right now? Force plates are almost an essential tool as a whistle and a notebook. So it's a little bit like GPS. I've always been pretty anti GPS and its rapid adoption. I remember a podcast with DiPrampio and we argued about its usage in the sense that the accuracy rate, particularly in decelerations and small-sided games, is so poor that you're getting an objective number, but its comparability, or more importantly, its reproducibility, is not great. And I think that's a significant challenge. We have to look at the quality of the data that you've got before you actually start to interpret it.
Yeah, no, it's a challenging one, isn't it? Because as you said, like you can get a 3D force plate or a 2D one, with most of them are 2D with like the valve stuff and the other ones that are coming through. And then do you want that 3D data, but do you want it to be usable? Do people know how to use it? To look at, are they going to analyze all of that information? So it's a whole minefield. So yeah, we're not going to definitely not going to solve it on this.
No, and I think actually something that was very interesting. I was doing a lot of work on athletic groin pain, and of all the published work that we've got, one of the common features that we found was that ankle rate of force development was deficient in a lot of people. If we look at ACL injury and ACL rehabilitation, ankle rate of force development, again, is deficient in lots of people. Because if you kind of imagine a scenario where you're spending more time in contact with the ground, there's more chance for everything above that to change. And I used to argue commonly, and Trevor Pryor, podiatrist, would laugh listening to this. I used to argue everything was top down. Like you can't adjust the tracking on a flat tire. But actually, I'm wrong. I've evolved in thinking. But biomechanics has taught me that actually the stiffness of the spring, the stiffness of the ankle, the ability to produce torque is vital. Because if it's in contact with the ground too long, you've got potential to injure further up the chain, or you've got potential for the weak point to give. 2D force plates are really useful in assessing that, but they're not useful in assessing the ankle independently without creating a contraption which has error in it to isolate the ankle itself. So the measure is common, and I think more work needs to be done on identifying features using better systems across clinical studies to advise the most effective ways of changing in terms of a biologically assisted rehab matrix to be able to provide those answers, which then can be applied everywhere. And you can use whatever tool you like then, try to guide and try and focus on that improvement. I'd have loved to do a trial looking only at rehabilitating athletic groin pain by focusing on ankle stiffness, because there's a proportion of people, regardless of all cause of groin pain, that will fix.
Yeah, no, it is really, really interesting area. And so when you went into Santry then, so was it with a remit to do the biomechanical side, or what was your overall remit when you went in?
It was to build a practice. The CEO at the time, a guy called Jeff Moylan, was very, very visionary about what he wanted to do. And Ray Moran, who was one of the owners and ACL surgeon, posed a question, was like, if people will travel around the world to see Bill Knowles, to rehab at his center, and people will travel the world to have surgery because of a surgeon, why could Dublin not become a destination for rehabilitation? And I'm pretty proud by the fact that in my last year there, we had over 200 different clubs from all over the world use the sports surgery clinic as a destination for rehabilitation. But I was looking for a point of difference. And I believed that biomechanics could give us that point of difference. And it was a gargantuan task. We produced 40 papers plus with no real budget, and which is greater than many university departments with grant funding and the like. And the board was supportive of that process. We were using, in many respects, research publications, many of which in British Journal of Sports Medicine, so a high impact factor, as PR. And that brought those patients from afar. We were very fortunate to treat some very high caliber athletes based on that prescription model. But it took a long time to get. But alongside that, we didn't advertise. And so the focus was always on the patients. And we went to 50,000 patients a year before I left. So it's been a pretty big growth process. And it was a real privilege to be able to marry research alongside that process. And also to develop many practitioners' careers, building Ph.Ds, which is very integral, I felt, to practitioner development, to be able to identify features to select. And Enda King went off to Aspetar, Neil Welsh there, Adele Fanning, and a lot of biomechanics staff who've done some phenomenal work, Shane Gore and Chris Richter, and Kieran McFadden.
And was it always something from your side? Did your role grow and change as you were there then throughout that 10 years?
Yeah, absolutely. I started providing medical service. So Aina Fowley was the Irish team doctor, and I used to nip over from London to cover for him when he was away. And I remember very vividly my first day walking in the 24 patient list, which sports medicine doesn't do. So I think one of the challenges in training of sports medicine, particularly in the UK and Ireland, is the volume of patients. And I walked into to 3 days of 24 patients. And to give you an idea, pretty much every one of those patients had an MRI scan after the consultation that was designed immediately afterwards. So I would have a patient returning on the same day with a hot MRI without a report, wanting an answer for what the MRI showed. So I would be sitting with an anatomy app, the MRI and the patient. So that 24 patients was really 48 patients. And I walked out on my first day, having started at 8, at 11 o'clock in the evening, still dictating as I walked back to the hotel to start the following day. I thought better at 7 o'clock. And the admin team at the time, Rachel Ryan, who's still there today, uh, was chuckling, thinking, she'd been told we need to make money from him, we need to fill the list. The list was jammed, and at the time, I'm not ashamed to say it, my knowledge of Irish geography was so poor. Patients could be travelling from Mayo or Ballina, where Joe Biden currently is, in the far west of Ireland, and it's a good 4 hour journey. On the map, it looks about an hour. So patients would travel from as far as that or far deep in Kerry, which is below Cork, 4 hours to come for a consultation. And whereas someone around the corner could be literally around the corner. And I think that's the scope of practice there, is that people will travel for expertise, but it's vital they go away with a diagnosis. And there's a lot of discord on Twitter mainly about patients and what we need and what we don't need. And I disagree vigorously. Patients don't need a diagnosis. They need confidence in the team that are looking after them. And I'd rather be wrong with that diagnosis. And I would always give them a percentage opportunity to say, look, I think, I'm 80% sure. I'm 70% sure. And what I would have loved to get to a model was that I could give a live data reading of the number of patients with the same condition and how long they were in treatment. Because very often, if you have a meniscal tear, a surgeon will say, it's 4.5K, you'll have your arthroscopy and meniscal repair, and then my job is done. The patient thinks I'm fixed. Clearly, they're not. With rehab, we're horrible at it. So you've got Achilles tendinopathy. We say you've got Achilles tendinopathy. One practice might use interferential. One practice might use loading. Someone might recommend collagen supplementation. Someone might recommend plyo. Our standardized care is awful, but equally we're terrible at a model. How many patients have you seen? Patients used to come to see us in Dublin for ACL rehabilitation, not because we were brilliant necessarily, but we published, but also we were looking after 1,000 patients plus a year. If you're a football club, you might be unlucky to have two. And so there's a currency of doing something lots and failing with those patients. You need to make failures in order to be able to understand what you need to change. And we're using data to try to minimize those failures. But I think that journey is very important. So we were trying to I guess learn from our mistakes, and I made a lot of mistakes in those early days of seeing that volume of patients. But I think it's essential. You need to be responsible, and registrars that I've taught and trained over the last 3 or 4 years needed to be exposed to that volume of patients, because without it, you need to be able to look. If you're going to use MRI as a tool, you need to be able to interpret it yourself, and you need to be able to explain that in terms the patient will understand. And I think I've managed to do that in the Irish training program, but I worry about training programs across the board because of a lack of exposure to patients.
And do you think that you mentioned about the failure and embracing that? Did you think that at the time as well, or is that something that retrospectively you think?
Definitely retrospective. So at the time, my main focus was I was English in Ireland, and so there was in some circumstances and natural I was ex-military English in Ireland, which was even more challenging. There was I needed to make friends. I needed to win that patient over, and I needed to service the demand. And I brought with it a very private UK practice mentality, in the sense that a private patient in England might expect a coffee and a newspaper. and sit in a nice waiting room. That's not what we were offering. 24 patients a day coming back to your results. We weren't able to offer that environment. It was too busy. It was packed. There was standing room only often in the waiting rooms. And but one of Aina Falvey's great, I think, message to me early on was that we wanted to care. We wanted to give them what they needed. We wanted to minimize the back and forth, but we wanted to give them a plan on the day. So we didn't charge at that point for physio contact. We delivered the first bit of rehab on the day as part of that overall consultation. And so you'd come, you'd get a diagnosis, you'd get a scan, you'd look at that scan, you'd be confirmed in that diagnosis pathway, and off you'd go. And certainly, I've recruited physios in the past. I couldn't environment. The shortest time I've had a physio work in the environment was a few hours. They came in, couldn't work in that environment, and moved on. But it's a challenge, and I think it worked very well. Well, we grew from 500 to 50,000 patients. So there was the success both financially, but also the patients improved, and it's been noticeable. The message I've got after I've left, in terms from patients seeking that elsewhere, that it's not widely done. So I think it was retrospective, my review of failure, not at the time. I needed to make friends and give them a diagnosis.
Yeah, no, I can appreciate that. And were you actually living in Ireland, or were you just commuting in?
No, I'd fly in from England, and I'd hotel stay. There was a hotel about 600 meters down the road from the clinic, and I would probably done, I'd say, close on 600 nights in that hotel. And not my favorite place. And I'd walk down the road, see the patients, and walk back.
So what was that like then? Just like, you must have gone into the city, I'm sure, but like,
Andy, to be honest, for the first year, I saw the airport, the hotel, and the clinic. It became a passion. I was absolutely devoted to the mission. I was determined to bring international patients to the clinic. I was determined to restructure and grow. And a lot of that restructuring was brutal. There was some redundancy. There was some changes of focus, and real urgency of action. And it wouldn't be unusual to have many of the teams sat back there at 11 or 12 o'clock at night planning how we were going to focus. And it's important to emphasize that, because you can look at the journey and say, yeah, you've got a PhD, you've got 60, 70 papers, you've written 2 textbooks. No one paid me to do research. Every bit of that research was done in addition to seeing 24 patients a day. It's all been self-driven. And I've been fortunate to be able to build into people's diaries and calendars some research time. So our newer physios who would be on PhD tracks would have a day and a half a week dedicated to PhD work. A lot of that would be patient driven, and they'd be seeing patients that were part of that PhD outcome study. But that ethos I needed from the team, because ultimately it was a commercial clinic, and it had to make money, and it was, that was the bottom line, and it couldn't just be about research, it couldn't be about the journey.
yeah. And then when you talk about some of the recruitment going on there, so how would you recruit there? So we've mentioned now again, was that a retrospective thing that you're looking at beyond the CV and through the gaps that aren't written there? What were you looking for when you were recruiting?
It was definitely live. So we made some mistakes, and I think, again, owning up to those mistakes, I put people in wrong roles. I probably over promoted SSC at sometimes, without the necessarily leadership or management skill. That I've got the physio S&C balance at times wrong, and I focused on the wrong bits of PhD activity at times. I think ultimately it was about trying to balance the team. One of our faults, and I think it's a good learning point, is we tended to recruit more of the same. So we were averse from recruiting people that would challenge the methodology. And I don't think that was intentional, but when I look back, that's what we did. Was that to our best advantage? I'm not sure. We still had good output and we did well clinically, and I don't think it was a fault. But I'm building a team at Nuritas at the moment, and what I've asked my individual managers, very much so, is to challenge the decisions I make now, because we've got one opportunity to get this right. And so as we build teams, we want hungry, driven innovators who see Nuritas as a reason or a platform to express their innovation. And healthcare is not very good at that, because we get overtaken by a job description, and we get overtaken by a percentage return on salary. We get overtaken by, and you only need to see the criticism osteopathy and chiropractic gets in terms of that model of multiple visits and therefore a potential for profiteering. Business is business at the end of the day. Healthcare is a business in private medicine, and I think people are very averse to raise prices. If you have a skill set where it's relatively unique, the price reflects that. And where if you're a clinician, there are only 24 hours in a day, and there are only 7 days a week. And if you're the service and you're the unique element of it, there's a capacity, there's a ceiling on what you can earn from that process. And I think one of the big career blocks for many people down the way is that ceiling becomes dissatisfaction. You can't earn more. You're excellent at your job and you're only getting better at it. But the way to reward that, there's ultimately a ceiling. You can only see a certain number of patients, you can charge a certain amount of money, and you can't change. And so I think excellence often struggles with that artificial ceiling, because you can't see, you don't know what's out there. You don't know what else, you don't know where your skill set will transfer to. I think I've been very fortunate in being able to make that move. And I think the military gave me that ability. You'd be forced to go from one job to another from every 9 months at times. And you never had the skill set in my head. I was responsible at one point for inspecting medical centers against a standard benchmark, very much like CQC. I didn't have a clue. I had no idea where you even find the benchmark standards, and yet then I had to re-engineer the whole process. But that's great, because it gives you challenge and it gives you opportunity and focus. And so I think it's something that we do badly in healthcare, because we get bogged down with the job and not look at necessarily other ways of doing that job.
Yeah, no, we were talking before about that, and I think it's really important. It's very easy to just get, like in COVID, I would normally be out three times a week minimum pre-COVID. Now I'm in the office probably 4 days a week, and
yeah,
I don't particularly enjoy that aspect of it. But we were talking about productivity and time blocking and all of these things and trying to be effective with it. But it is really important to spend time looking at creativity and doing that. It is for me anyway. This is what I want to be doing. So in terms of, like, for you, how do you do that? Like we talked about self-help and professional development and so on. How do you make sure that you're doing that alongside everything else that you're doing?
Yeah, I think I've evolved, I think time to think is desperately important. And for one big period of my life, I was living in Australia and working in Ireland, so I would every month jump on a plane to Melbourne, and I'd have a 22-hour flight, which was great thinking time. And at the time there was no internet on planes, and so it was relatively quiet. I've become a big believer in Pomodoro, in terms of taking those 25-minute work blocks and then leaving 5 minutes of just downtime between 25-minute work blocks. And I think that ties in very well with Parkinson's law in terms of setting a deadline. So work expands to fill the space that you give it. And so setting tight deadlines and giving yourself 25 minutes on a project, it keeps you fresh. And particularly in my role at the moment, where I might be jumping from data science to cell biology to VC discussions to marketing, being able to jump from one thing to another, I think helps. And I think that applies very well to healthcare. You can take a step back though and say, well, actually, if I'm a practitioner in clinic, how on earth does that work? Because I've got X number of appointments. But I think you need to build in time to be able to think, because at various stages of that journey, I've become obsessed with or focused on one piece, which has sometimes been the wrong piece. I was tasked with starting a research foundation for the clinic, and I built a scientific advisory board, but there were insurmountable challenges in terms of the business that we probably could have looked at earlier and decided that it wasn't going to work. But between Pomodoro and Parkinsonian, I think those two are really good guides. Everyone says they're an avid reader. But we were touching on this earlier on in terms of there is pressure. There's pressure to be current and learn. And I was saying one of my favorite apps is Pocket, where you can download the page that you're looking at to an app. It's available offline, so you can read it on the plane or you can read it on the tube. But there's a knowledge accumulation there, which is great. But as I said to you earlier, like I've got 120 notifications in Pocket of things that I think are important. We're halfway through the month. If I don't have time to clear them, am I ever going to utilize them? And some of that is because I'm in a new field. I'm looking at proteomics and I'm trying to understand antibodies. I'm trying to understand protein pockets and machine learning of them. So lots of it's new, but equally, there's a limit to what we can do. And we were talking about Audible earlier on, and I think we need to make snapshot judgments in many respects as to what value it does. I subscribe to short form, who will read the book for you effectively and give you a short encapsulation of it. I think you lose the nuances. One of the best books I've read was a thing called The One Thing. And it's a lovely idea that you have one thing to focus on every day. And I think it fits with Pomodoro very well, because we all have to-do lists. And to-do lists just get longer and longer and longer. But I think the one thing takes a real focus on it. And I brought that into my data science teams at the moment in terms of, tell me the one thing this week that we're going to fix, or is the main focus, or is the main problem. And I'll give you an example. We were discussing at the start of the week one thing in data, and you can imagine the amount of data a mass spectrometer produces. It's essentially coding proteins into a string of numerical or word letters, alphabetical letters, and it produces millions of bits of data. And so the one thing on that list was build a process to export data automatically or whatever. But I also asked them for the next 5, because I want to understand prioritization, because prioritization is important. But actually, for me, the fact that the data backup was failing was third on the list, and I couldn't understand why that wasn't number 1 on the list. So I think by taking that approach in terms of how we prioritize and what is the most important thing we need to get done today is something that I brought through SSC through to Nuritas is really important. But I think it's building time. It's building time to be able to address it. And I think if you can find an hour in the day, Pomodoro works. 25 minutes, 5 minutes, 25 minutes, 5 minutes, to be able to switch through 2 topics. And I love one thing in terms of being able to focus on what to pull in there. As for reading, I love it. I love learning, and I think my reading has gone through. I guess for passion, I would read autobiographies because I love learning from other people in a very wide field. And the leadership management books, I sort of flick-flacked around. I've looked at Thinex's work in terms of marketing because it's a big part of my new role. But also I think you can learn some life lessons. But I think I've learned more over the last 18 months on looking at the startup world, the grind world of networking, and because there are lots of people in the same space, and our ability to network within healthcare is pretty poor. People say you should surround yourself by 5 people at a higher level than you in order to build your growth. That's very hard to do. It's very hard to do without a very strong mentor. And it's relatively easy in your junior career. I think it gets an awful lot harder as you get higher up. I'm very fortunate to have been given mentors in my new role, which is phenomenal for me personally. But I think is vital for everyone to try and find somebody who can give you some of that insight we were talking about earlier. What Google need to learn when you're at school. If you're going to want to work for McKinsey, what do McKinsey need along that way? What jobs actually exist at McKinsey? How do you get into banking? How do you work for Grant Thomas or for PwC? What's available? Because healthcare becomes very insular, and there's a whole world out there that's not healthcare. And the talent that's in healthcare, because of the standards of I think, to get into it, and also the pressures of working in professional sports or private practice or clinical or in academic medicine, are incredibly transferable out of that environment. But in order to know what's out there needs to be a shepherd along the way, but also a teacher at the end. And I don't think they're very readily available. And I think, we have to look back. And I think I was very fortunate in my early medical career to met Kelvin Giles and Vernon Gambetta, 2 guys who I think have given more back to the strength and conditioning industry than anybody. Often criticized, often I say criticized for dinosaur or old school behavior. I think that's so far from the truth. I think anyone who says that doesn't know them. I haven't actually looked at what they are. I think Kelvin Giles was innovative beyond belief in terms of a matrix system of assessment of physical competencies. And I think Vernon Gambetta's ability to break down coaching across the board is phenomenal. But both have reached down to help other people along that track. And I think that's one of the things, one of my goals, I would say, for my next 2 or 3 years is to try and reach back down the track, because I've jumped from one part of medicine to another and been very fortunate for the Navy to help me along that way in my early career. I then hit a very lull where I didn't have that mentoring, that I was self-determined. But now I've got that transition again. And I think a lot of people are lost in healthcare who have an awful lot to give outside of it, but the world appears closed off. I think it's an exciting time to be able to look outside where they might be.
Yeah, no, I definitely can see what you mean. I think it is quite insular in what they do, and they're getting on with what they're doing. And then it is noticeable when someone like you say steps out of that. It's not that common when you actually see, and you're going into that different environment, which is, yeah, it's really interesting. And yeah, I mean, I'm going to check out one thing, and I've not heard, although it did sound like it was 6 things when you said it's one thing plus the next five.
Yeah, it's one thing you have to get done. I think it's a great resource. It's a phenomenal way of approaching life.
Yeah, no, it's good. And then just any autobiography recommendations? What the ones you've done recently? I'm a big fan too of those.
Do you know, it's more a case of what I didn't like and it's probably more intuitive what I didn't like than I did. I guess one of my favorites has been Schwarzenegger. A phenomenal man, has jumped careers multiple times and has become, at various stages, was it unbelievably driven. The early years, where he was commercially astute enough to put money into a business that in terms of building, some phenomenal side stories about buying land and wanting to build an airport and random stuff. The bridge and the determination to go from bodybuilding into acting, and then subsequently acting into politics. You can criticize that part, you can criticize the politics, you can criticize lots about the end man, but the journey's phenomenal. And the audiobook is well worth it, because you get to listen to him in the first couple of chapters, which are equally phenomenal. On a similar vein, there's an autobiography called Who is Michael Ovitz? Michael Ovitz is a media talent manager, and that under describes him, but to try and encapsulate it in a sentence would be remiss. Again, phenomenal journey, self-determination, but use multiple hats at various times to build an empire in both athlete and media representation. Great book for multiple stories along the way in terms of who he's represented and the various deals done along the way, and overlaps of it with Schwarzenegger, because the whole Schwarzenegger-Stallone saga, where they were competing against each other in a similar space, is a great story. But for me, two of those, I think they're definitely high on the list, and I'd recommend wholeheartedly.
Yeah, I love Schwarzenegger's. Just again, with you just summarized it well there. But to become the absolute best at pretty much everything he did, those 3 different careers,
Yeah,
shows a massive character.
yeah, absolutely. I think it's an insight into drive, but also an insight into how you can fail and restart, which I think is really powerful.
And have you done Phil Knight's Shoe Dog?
Yeah, again, a big fan of it. I think there's bits missing from that though that I'd love to hear. It's as with all of these things. When I think you follow an empire being built, I think you learn more from the failings, and he gives you some of that, but he doesn't give the shoes he stepped on, and he's definitely stepped on some shoes, and he's definitely being cutthroat at various times that understandably are glossed over, and I don't love. I mean, I think the one that's not a biography and is still ongoing, but is a fascinating story, is Elizabeth Holmes, and the Theranos story. And the
What's that one? Who's that?
it's a Elizabeth Holmes is about to start a jail term in the US. She was once number one on the Forbes list of new entrepreneurs and modeled herself on Steve Jobs. She invented a micro blood capillary system that could give you blood results from a capillary. But sadly, it didn't work. But she sold investment and had Secretary of State of the US on the board. And there's a whole story of intrigue and deceit and startup culture in med tech, which is a phenomenal story. I think it's a Netflix show or a Prime show, as well as an ongoing story. But phenomenal lessons learned along that way.
Yeah, no, I'll check that one out. And I know I've kept you for ages here, so apologies. Last one here. So I know you mentioned that when you visited Facebook beforehand. Just tell me what you saw that resonated with you there.
Sure, and I think I was critical of this. I walked into Facebook, and there were signs everywhere, sort of motivational signs as you walked in through the turnstiles, as they checked in and out staff, and it was better done than perfect. So and at the time that message didn't resonate at all. It was a case of, like, surely you need to get something done to execution to a level. Like, what's the point in doing something badly? So do something badly better than completes better than good. Didn't make sense. I've learned a lot from that. You need something on paper. Something needs to be finished. And I think that Parkinsonian law, in terms of task expanding to fill the time available to it, if you set something a deadline, you've got something to work on and it can be refined. Too often we allow things to drift. We're very unwilling to fail or to say no or to stop something. And I think that better done than perfect is a real message for that. It's better to know than not know. So you need to commit. You need to throw everything at it, get it done, and then make a decision. And otherwise, it's very difficult to make a decision. And I've learned a lot from it. Helped me a lot in the last 12 months.
Yeah, seems to go back to actually what you said about your diagnosis for people as well, and just committing to something and with putting that around. Brilliant. Look, really appreciate your time. I've really enjoyed it. There's loads of other books I'd love to brainstorm with you, but maybe for another time. But best of luck. Congratulations on the new role and best of luck with it. And I look forward to seeing how it all goes for you.
Absolutely. Andy, thank you very much.
No problem. Cheers, Andy. Thank you.